load too. So.
Exactly.
Hello. Hello, welcome. Thank you for joining us for Berkshire Sports and Wellness's presentation of the dynamics of the ACL, keeping your knee strong and stable. We are going to have Dr. Jonathan Cluett speak about injury prevention and a little bit about the surgery if you do have the misfortune of tearing your ACL, and followed by that we'll have Elise Nichols speak about how an ACL is rehabbed after surgery. And then after that we'll do a question and answer session where we'll be joined by Dr. Sprague and Dr. Namkoon as additional orthopedic surgeons, where you can ask any of us questions regarding the ACL, the knee, and other questions as you might come up with them during our presentations. After that, we will have the opportunity to use our learning and try out different exercises and activities that will help you to strengthen the areas around your knee. My name is Yasmin Wilkinson. I'm the coordinator of Berkshire Sports and Wellness. I'm an athletic trainer at Williams College and an athletic trainer working with the Berkshire Sports and Wellness program at Berkshire Health Systems. And at this point, I'm going to turn it over to Dr. Cluett.
Thanks, Yasmin. Oh, nice. Thank you. Thank you. Let's see. Get that file. I like to throw this picture up at the beginning of a sports-related talk just because it's kind of like looking at an Escher picture or something. You just kind of stare at it for a little while and try and wrap your head around what's taking place there. We're actually not going to talk about this type of injury today, but what I do want to talk a little bit about are ACL injuries, and specifically some interesting work that's been done over the past couple decades in understanding both why ACL injuries occur and what we can do to prevent them from happening. And essentially what I want to talk about is a subject that we could call preventive biomechanics. And I mean, in a sense, you know, I think often we throw up words like that to make ourselves feel and sound a little smarter than we actually are. But preventative biomechanics, it's just a way of saying that what we're trying to do as clinicians, as researchers, as athletic trainers, as physical therapists, is break down what's happening in our body to numbers. So we're just trying to assign numbers and forces and vectors and try and understand when we're doing activities, be it sports-related activities or athletic activities, what's happening in our body, what forces are occurring, how can we affect those forces in a way that maybe we can do these activities without having the same risk of injury occurring. So what I want to focus on is the role that the ACL plays and the role that biomechanics play in determining if somebody's going to injure their ACL and what we can do about preventing that. And I think there's this common misconception that an ACL injury is just something that happens like that. There's no control. It just happened. They were unlucky. Just bad circumstances, they tore their ACL. I'm going to show you a video of somebody tearing their ACL. So hopefully you can see, I know the light's not great, but this is a soccer player. This is actually Michael Owen. He's a English national team player, and this was in a World Cup qualifying match.
Just watch his knee.
Was it in the World Cup? What? Group stage of the World Cup. And I think they're playing Sweden, and this was about 8 years ago or so. And he tears his ACL and he's out for the remainder of the World Cup. So watch his left knee as he's making this turn here. He plants his foot, there it goes, down on the ground. So I think there's a couple things to notice about what happened when he injured it. And the one that jumps out to me is no one else is around him. He's by himself. He didn't get hit. He wasn't tackled. No one lowered their shoulder into his leg and took him out at the knees. He was by himself. The closest guy in the picture was one of his teammates who was running the same direction. So no one's around him. He plants his foot on the ground, he makes a turning maneuver, and his ACL goes out. And what we're trying to do by understanding the biomechanics of that is try and understand what forces are acting on the knee joint that caused that injury to happen. And what the argument I'm making, and I think that the research will support, is that's not an unpredictable injury. There are ways to assess the likelihood of that occurring, and there are things that can be done to prevent it from happening. About 70% of ACL injuries are what we call non-contact injuries. They happen with no one around the injured athlete. So they're running along, they make a move, they cut, they turn, they twist, and then they tear their ACL. So about 70% of the time, there's some variability by sport. So some sports do have higher rates of contact injuries, but by and large, that's pretty consistent across most sports. The other thing that's interesting about ACL tears is anyone who's had one, and I know there are some people here, knows they take a long time to get better from. When somebody tears their ACL, you're talking about a minimum 6 months, but usually about 9 months to a year of recovery. And ACL tears are the number one reason why professional athletes, and this is, again, consistent across sports, it's true in the NBA, it's true in Major League Soccer, number one reason why athletes are missing sports participation at that level. And the argument I want to make today is to tell you that at least half, if not 2/3 of these injuries can be prevented. And I'm going to tell you how we can prevent those and how we can predict which athletes are most likely to tear their ACL. The one other interesting thing that I want to convey is this issue with female athletes and ACL tears. The risk of a young woman tearing her ACL is about 2 to 8 times higher than a young male athlete. So if you take similar groups of individuals, so say high school soccer players, take a high school men's soccer team and a women's team, and just compare the likelihood that one of the athletes on that team will tear their ACL, the risk in the female athletes is much, much higher. And again, there's some variability by sport, but it's somewhere between 2 and 8 times increased risk. What we've seen in the last few decades, essentially since Title IX, is an explosion in young women participating in sports. And because of this, ACL tears in especially that young female population is an epidemic. And this is a huge cost. It's a cost to society in terms of medical dollars. It's a cost to these young athletes who are spending a lot of time out from injury. It's a cost in terms of this increasing the possibility of young athletes who tear their ACL developing problems with their knees later. And we can prevent these injuries from occurring. So I'm going to show you another athlete here. There's a women's basketball player, the one on the right. Her name is Shea Ralph. She was, if anybody follows women's basketball, University of Connecticut is kind of the top of the cream of the crop, and she was one of the original stars of UConn kind of before Diana Taurasi and Sue Bird and all these athletes that have made it to the NBA, WNBA. So Shea Ralph tore her ACL 5 times. She came back from ACL tears 4 times. And she ended up being drafted in the WNBA but never played a game because she wasn't able to come back her 5th time. So what I want to do though is not just talk about these injuries occurring, but actually watch her knee as she lands. And I know it's a little bit hard to see, but I'm going to go through this one more time. And try and keep an eye on that right knee as she's coming down. So it slows down here, but you'll see it right here. And just watch the position of her leg. Watch how she's landing. So you can notice a couple things. Her foot striking the ground, she strikes it very hard. Her knee's in a very straight position. And it's kind of off to the side, not under her center of mass. So before I get too much further on exactly why ACL tears occur, let's talk just very briefly about joint stability. So this is an issue with every joint in our body. Joints have to be stable. So there's a balance between how much a joint can move and how stable it is. And every joint in your body, you can talk about shoulder, hip, knee, ankle, has mobility to the joint, and it also requires stability. Now there's 3 things that contribute to how stable any joint in the body is. The first thing is just the anatomy of the joint, the bony architecture of the joint. So some joints are just inherently much more stable than others. For example, the hip and the shoulder are both ball and socket joints. The hip is a ball that sits in a deep socket, so it's very stable. And while things like hip dislocations and subluxations can occur, they are incredibly rare injuries. Contrast that to a shoulder, which is a ball that sits in a very shallow socket. And the shoulder joint, we often hear about shoulder instability and shoulder dislocations. The second thing that contributes to how stable a joint is are the ligaments around the joint, what we call the static stabilizers. And what I mean by static stabilizers is the length of those stabilizers stays in one position, static. And so there's 4 major ligaments around the knee joint. The ACL is the primary stabilizer of the knee. There's another cruciate ligament, so cruciate means crossed, and you have an anterior and a posterior cruciate ligament in your knee. You also have 2 collateral ligaments in your knee. There's also a bunch of other smaller ones, but those are the 4 primary ligaments. And every joint in the body has ligaments around it. And the third thing that contributes to stability, and this is what I'm going to focus on, are what we call the dynamic stabilizers. So these are the muscles and the tendons that surround our joints. And they are very important stabilizers to the joint. And the first 2 things, the joint anatomy and the static stabilizers, you can't really change those. You can have major reconstructive surgery and affect those. But really, the only variable we can control are what's called the dynamic stabilizers, and that's what we call the neuromuscular control of the joint. So let's take a look at what happens when somebody tears their ACL. This is an individual getting ready for ACL surgery. They're under anesthesia, and a force is being applied to their knee. And if you can see carefully, what's happening is the knee bends, it's shifting. So it's going from being lined up to being out of joint. So it's basically subluxed, and then as the knee's bent, it comes back into alignment. And what's happening when an athlete tears their ACL, every time or many times when they go to cut or pivot or twist on that knee, it's doing exactly that. And when you're not under anesthesia, that's very painful. And you tend to fall down. So that shifting of the knee joint that you see right there is the knee coming in and out of joint. And so when athletes tear their ACL, their joint becomes unstable. They can't trust it. Now, what happens, I should say how you tear your ACL, not how you are, but how you tear your ACL. So what happens when an athlete tears their ACL is the forces acting on the knee lead to abnormal rotation and alignment at the joint. And this is something that we call dynamic valgus instability. And all I mean by saying that is the leg gets in a really awkward position, causing a lot of force to occur right at the knee joint. Athletes who tear their ACL, they tend to hit the ground hard. They land with their foot firmly planted on the ground, and their knee tends to be pretty straight. What this leads to, all of these factors, is all of the force, going back to this biomechanics issue, all of the force gets funneled right into that ACL. Athletes who don't exhibit these characteristics absorb that energy throughout the extremity. So think of it as, we've got 100 units of energy, and if all 100 units are concentrated on the ACL, it's just not strong enough to hold up. But if 10 of those units can be absorbed by the ankle, and 20 by the leg, and 20 by the knee, and some in the hip, and some in your core, those forces get dispersed across the entire extremity, and that leads to prevention of these types of injuries. So let's talk about a couple of these forces. And the first one I want to talk about is ground reactive force. And don't pay any attention to any of those numbers. But if you just look at the picture, what we're talking about is how people land. What forces are acting on that impact when they land from a jumping position. And if we just take two groups of people, and the easiest is to take women who tend to have a higher chance of tearing their ACL, and men, and just have them do a jump. So you have them stand in one position, have them jump forward, and measure the force acting on the ground when they land. What we see is in women, there's this very high peak of force that occurs very early on when they land. So what's happening is when they're jumping, they tend to land in a very upright position, straight knees, foot comes into firm, hard contact with the ground. When we look at a group of men, their tendency, and again, it's not every, some men don't land very well, some women land very well. But if you take a large group and look at the average, most men, when they tend to jump, they will land in a more athletic position and absorb that energy throughout the extremity. Here's what I'm talking about when I use that word dynamic valgus instability. And what I mean by that, again, is the position of the leg in space. So if you look at this athlete who's kind of coming down into an athletic position, it kind of starts out okay, a little bit straight, and again, that firm position against the ground with a straight knee. But when she's coming down into this athletic position, there's a huge angular force occurring right at the knee joint. And again, the center of the body is not really supported by her legs. So all of this is concentrating a large amount of force right at the knee joint. So I'm going to go back to that picture, the video, Shea Ralph landing. And just, again, watch her knee. Look at that ground reactive force that she's hitting the ground with. Look at the position of her knee joint when she lands, off to the side, caving in like that. Look at the straight knee right when she lands. So she's exhibiting a lot of characteristics of somebody who's very likely to tear her ACL. So what I would argue is this injury didn't have to happen. We could have looked at the way she was moving and done things to change that to lower the chance of her tearing her ACL. So let's talk about predicting risk. What we mean by that is we want to screen athletes and pick out those athletes that are most at risk for injuring their ACL. We then want to build an intervention program and teach them how to not do that. And ideally, we'd be specific about how we do that with patients. So There's different ways to address this. One is with what we call ACL prevention programs, which are kind of broad, let's teach an entire group, an entire team, some ways to move their body in a safer way. Another is to tailor this to a specific athlete and assess that individual athlete and say, these are the biomechanic issues we see that are causing problems, and here are some specific things we want you to do. But think of this like, if we have a young athlete who wants to play soccer, wants to get better at soccer, and they are lousy at dribbling the ball, we don't just throw up our arms and say, well, I guess they're going to be lousy at that. We teach them how to do it. We train them. We have them do drills. We have them learn that skill. These same skills can be learned. We can teach people how to land, how to move, how to control their body in space. And by doing so, we can reduce the risk of ACL tears by about 50 to 70%. And what's really interesting, and we're focusing on ACL injuries in this talk, but these same principles have been shown to be effective at reducing all sorts of other lower extremity injuries, including things like patellofemoral pain syndrome, something people call chondromalacia, medial tibial stress syndrome, something people call shin splints, ankle sprains. All of these injuries can be addressed with this dynamic control of the extremity. So very quickly, I just want to talk about some simple screening tests that you can do with athletes. And these can be young athletes, weekend warriors, people who just want to become more athletic and lower their potential for injury. So the two tests, and these aren't the only ones that can be done, but they're just two simple tests you can do. One shown on the right of this image, just like we talked about when we were looking at ground reactive force, have athletes stand with both feet on the ground and jump forward and land with both feet on the ground. If you want to do it from a slight step, have them stand on a step and jump forward, that's fine. But just watch how they land. And watch if the athlete's jumping forward and landing in a very upright position, or are they standing and landing in a very athletic position. The second one you can do is called a single leg squat, shown on the left here. And when I'm looking at athletes, what I'll have them do is stand on one foot and just start doing some squats, like this. And you don't want to have them do one or two, you want to have them do 10 or 20, because you're trying to kind of get their muscles to fatigue a bit so you can get a sense of what's happening with their body. If you see their leg wobbling all around, you know they don't have great control of that extremity. If you see their pelvis tilting, you know that their core needs some work in order to better control the stability of their pelvis. So those are two very simple tests, and we're going to be looking at some of those. And then what you want to do is teach movement. You want to teach athletes how to land, how to roll their foot when they land, how to flex their knee, how to activate the muscles around their hip to control rotation and position of their extremity, how to maintain their center of mass over their lower extremities to maintain in a safe position. And you want to teach control of the hips, the knee, the ankles, so that forces that are acting on the extremity can be dissipated rather than concentrated, leading to these injuries. This is what we call an athlete's neuromuscular profile, how they move their extremity. And we can alter that. It is not a fixed thing. We can affect that risk. So we want to teach things like proper landing position. We want to teach athletes how to have control their center of mass, to control the stability of their extremity, especially when there's abnormal forces acting on their body. We want to teach something that we call dynamic control. And you're going to see this device, the 3-act slide, is right over here. This is a really cool development in rehab for orthopedics. And what they're doing is they've designed a device that teaches how to control your body and how to control your movements, not only in one plane moving forward and backward, but in multiple planes, in rotational movements, and teaching athletes how to have good, strong control of their body to prevent injury. I think this is really exciting stuff because this works. For a long time, we didn't really understand why ACL injuries occurred, why women had such a higher risk of tearing their ACL. All of this comes back to this neuromuscular control of the extremity, the dynamic control of how we move our bodies. And we can reduce the risk of ACL tear, and like I said, as well as other injuries. If you've ever heard a sports radio or a sports newscaster say something like an athlete is injury prone, to me, that's all this is. Injury prone, all that means in athletics is that that athlete needs more work on their dynamic control of their extremity. This has been proven in randomized controlled trials. This is not somebody's theory, it's not what I think. This concept of neuromuscular control is very well understood. The real challenge in all of this is implementing these programs to prevent injury. And whether or not we're talking about high school, college, after college, weekend warriors, or down the road as people want to remain active later in life, it's very hard to get people to do these preventative exercise activities. And I'm happy to talk about why it's such a challenge, but it's very hard to do. What I would argue is the best way to ensure that athletes are doing these things is it's got to be thought of as a performance enhancing activity, not an injury prevention activity. So what we're trying to do is increase the athleticism of the athletes who are doing these activities, and the injury prevention side of it is just a bonus. So I'm going to wrap that up and turn it over to Elise.
Okay, so my name is Elise Nichols. I'm a physical therapist at Berkshire Sports and Physical Therapy. So I'm going to talk about ACL rehabilitation. So what to kind of expect if you tear your ACL, and then you come to see one of me or my colleagues or other physical therapists' lovely faces. I'm going to kind of give a generic overview. Every situation is different. Every tear is different. Every surgeon is different. Their types of procedure that they do is different, so that might tweak rehab just a little bit. I put this picture up because everybody probably knows who this is. Adrian Peterson he plays in the NFL. He tore his ACL 3 years ago, and then he came back like extremely quickly, and then he won an MVP, and everybody thinks that their ACL rehab is going to be like that, and that is not typical, okay? He's the exception, not the rule, so you can't really go by, kids come into my office and they'll say, well, can I play, I have a big game, coming up, and I say, when? Like, 3 months. You're not going to be playing back to soccer or football in 3 months. So he is the exception, not the rule. Okay, this is just a little bit of my background. I went to Union College. I played Division I ice hockey there for my undergrad. After that, I realized, okay, I have to get a job, and I can't just play hockey for the rest of my life, unfortunately. So I got my master's at Springfield in exercise science, and then I realized that my debt wasn't so high, so I decided to go back again and got my doctorate in PT. That's just a couple. I have some experience working with athletes at different colleges. I worked with the Springfield Falcons, which is, they're in the AHL. I think they're now the affiliates of the Coyotes, I think, for the NHL, but they used to be a long time ago, I think they were the Rangers. Irrelevant. Anyways, I worked at Springfield College, Williams, Berkshire Battalion. That used to be a low-level professional hockey team in North Adams. If you guys remember, they were here 1 year. I currently work with a lot of PHS athletes. I see one in the audience today, but I won't call her out. And I worked at Loomis Chafee Prep School. Okay, so ACL surgery and rehab has changed dramatically. So you used to have surgery and then you would be immobilized. You weren't allowed to move your knee, you weren't allowed to do any muscle activation. That was decades ago. Now, immediate range of motion, surgeons want you, into PT right away. Immediate range of motion and immediate muscle activation. Pre and post-op are very important. A lot of times surgeons will have you come to PT before your surgery if your range of motion or your strength isn't where they want it to be, because the better you go into surgery, the better you're going to come out. So they don't want you to have a poor outcome, neither do I. So a lot of times they have you come see us first so we can kind of work on your range of motion and some of your strength before they cut. Yeah. Okay, so when you do come to see us, controlling swelling and decreasing pain obviously is number one. I should have starred this. Range of motion is extremely important. It's the number one thing that we want to work on. After surgery, your likelihood, I think I talk about this later, your likelihood of arthritis goes up dramatically after ACL repair. So if you, even like a couple degrees that you're lacking in range of motion, your chances of arthritis go up even more than that, okay? So range of motion is extremely important. Regaining your strength and then regaining the static and dynamic stability that Dr. Pruitt already discussed. So why do you need PT? Well, the surgeons are good at their job and they do a very nice job. However, I think that PT is the most important fact. I think that everybody probably here believes that also, that PT is the most important aspect. It can help reduce your risk of re-injury, and it can help you get back to, obviously, your activities. Later, a couple more slides, I'll get into it. We talk about that rehab, or that injury prevention that Dr. Pruitt talked about. So the end phases of ACL rehab are kind of like the pre-phases before you even tear your ACL. So working on that stability, learning how to control your body movements, to decelerate, to cut, to pivot, to move in all those different directions. So there is some overlap. And there's different phases, and I'm just going to talk about kind of a broad, what you would expect. So some goals: protect that reconstructed ACL. If you go too fast in your rehab, and the beginning parts of rehab are very important, if you rush and you don't let that ACL heal and you end up re-injuring it or stretching it out, stretching the graft out, I would not want to be you going into their office. Okay, they're not going to be happy. So we have to protect that ACL, okay, first and foremost. Reduce some inflammation and pain. You are going to have pain. Some have more, some have less, but you just had surgery. Pain is normal. It'll be okay. We'll get it better, okay? Restore range of motion of the knee. Again, I should have started that. Number one importance, that's what we're looking for. And then strength training, balance and proprioception, which is that dynamic and static stabilizers of the knee, and then finally returning to activity. So I broke this down into about 6 phases. Again, there is no actual protocol that we just follow with our head down and have you run through. That's not what we do. But I did give kind of a basic of what you kind of should expect. Okay, so phase 1 is the acute management. This is right away, right after surgery, the early phases, okay, about 0 to 2 weeks. We're working on some range of motion, we're working on pain, we're working on inflammation. You might need help with how to use your crutches or how to get in and out of the brace, stuff like that. Phase 2, now before you get to phase 2, I like my patients to at least have about 90 degrees of motion. Again, if you had a meniscus repair or some articular cartilage damage that the surgeon had to fix or whatever, this might change, but overall, I like patients to have about at least 90 degrees before we can go into phase 2. So phase 2 is, basic strength and proprioception. So we work on, strengthening the quads, strengthening the glutes. Nothing too intense, but again, it's really patient. It's based on the patient. I mean, if you're able to fully weight bear because you just had your ACL repaired, then we will do more higher level things within reason, not to injure your new repair, but it's based off the patient. So between 2 and 6 weeks, full range of motion. I want full range of motion in that knee by 6 weeks. off the crutches at about 2 weeks, and then out of the brace by 4 to 5 weeks. Again, if you don't have control over your quadriceps, you can't, do a straight leg raise, or you have no quadricep activation, then probably you're going to be on the crutches and in the brace a little bit longer. So it's just based off how the patient is doing. Okay, so this isn't, I don't get to 2 weeks and immediately take your crutches away, but if you meet that criteria, that is usually when I want the crutches off. Again, phase 3, there's different criteria you need to kind of fit into until we move on. This is more functional and dynamic strength, so you'll be on the bike, you could be on the elliptical by 6 to 8 weeks, doing more squats, doing more balancing, throwing a ball against a wall or against a trampoline, stuff like that. So more functional and dynamic strengthening in that phase. Phase 4, this is usually everybody's favorite phase because everybody says to me, when can I run, when can I run, when can I run? That's the biggest question. So usually about 12 weeks, you can start running in a straight line, jogging in a straight line. We do it on the treadmill at work. It's usually a return to running program, so you don't just jump on that treadmill and crank it up and run what you were doing before you tore your ACL. We gradually do it. You usually start, 1 minute jog, 1 minute walk, 2 minute jog, 1 minute walk, stuff like that. We can start some low-level jumping activities by phase 4. Both legs, small movements, learning how to control when you land, stuff like that. Phase 5. So this is more of where it kind of overlaps with Dr. Kluwet was talking about with injury prevention or sports performance training. So this is about 5 to 6 months. You'll start doing a jump program that's more organized. There's specific exercises that we like you to run through during this program. Independent with the gym program, this is huge. I mean, we only see you 2, maybe 3 times a week. So there's 5 other days of the week that you're not with us, so it's important that everyone's doing their home exercise program at home, that they're going to the gym on their own, because I can do my job, they can do their job, but if you're not doing your job at home, it's going to make your recovery longer than you want. Non-competitive situations in cutting and pivoting. So if you play soccer, you're going to start doing, with your sports brace on, you would get a sports brace, you would start doing drills, in and out of cones, dribbling with the ball. If you play basketball, different drills, you can shoot, stuff like that. Non-competitive, nobody against you, nothing like that, okay? And again, around 5 to 6 months. Return to play. 6 to 12 months, more like 9 to 12, like Dr. Kluwet said, okay? So 6 to 12 is kind of a broad average, but we really would like more 9 to 12 because it just gives that graft a little bit more time. It gives you more time to get ready and then decrease your chances of re-tearing it or tearing the other side. People always ask, how long do I have to wear my brace for? Well, it's usually up to about a year that you wear your sports brace, and then it's pretty much patient preference. A lot of people don't need it after a year. They feel fine, they feel great. I never see them again. See you later, they're fine. Other people like to wear a little bit longer, especially if they went right back to basketball and then they start softball right away. They feel a little bit more comfortable wearing it through softball, and then probably over the summer they'll get rid of it. So it's really patient preference, but definitely up to a year you'll be wearing your sports brace. Return to sports criteria. This is important. MD clearance. These guys have to say, yeah, you're good to go. And most of the time they say, what does your PT say? As long as they say yes, I say yes. I don't know so much about these guys, but Dr. Sprague just says whatever Elise says. So thank you for that. Great. Full range of motion. We don't want any swelling. Good stability on ligament testing. So there's different tests we kind of put your knee through to make sure that the ligament is nice and strong. Full strength compared to the other leg. So what Dr. Kluwet was talking about with that single leg test, we do that throughout rehab. And you might feel like your leg is strong enough, but then we put you on the other side, you're like, oh, this leg's a lot stronger compared to the other side. So we kind of use your good leg or your stronger leg, your non-injured side, to compare it to the injured side. And different sports-specific functional tests will put you through, and you need to be able to run and jump without pain or a limp. Okay, you can't go back to basketball or football or soccer if you're running with a limp. Okay. So, successful outcome. 3 parts. 1, their part. They'll do their part. Don't worry about them. They'll do their job. Second part is my part. So, putting you through a good physical therapy program, making sure you're following it, pushing you while you're there, nagging you about making sure you're doing your exercises at home, because some of us like to slack, but, so that's my part. 3, your part. Huge. I should have started that. Okay? Patients who do stuff at home and on their own and listen to what I say and wear the brace when they're supposed to and do exactly what they're supposed to are far above everybody else. Patients who don't do stuff at home, I can tell. We can tell when you come in that you haven't done your stuff at home. Okay? So the third part is very important, making sure you're doing stuff at home. And I think I'm done.
Thank you to Dr. Cluett and Elise. Dr. Cluett, Elise, and now are going to be joined by Dr. Sprague and Dr. Namkoon over here at the table. If you have any questions about prevention, if you have any questions about the rehab process or how they overlap, you're welcome to ask any questions. I will repeat the questions so that everyone in the room can hear, and then we'll get an answer from them as they come up. And then after we answer any questions, we'll move on to our next section. Are there any questions? Oh.
My name is Nina. I just have a question for Dr. Cluett. Talk a little bit about the helping to prevention to prevent, and what you talk more about
Sure.
what the lies are.
Yeah. So, you know, these ACL injury prevention programs what tends to happen, so here's the story, is you have a high school soccer team and 2 or 3 girls go down with ACL injuries, and a parent goes on the internet, finds out about this stuff, learns about it, does their research, goes to the coach and said, hey, we don't have to have all these injuries, and I want to help make sure this happens, and they get motivated. And then the ACL prevention stuff starts to happen. And then the kid goes on to college, and the parent leaves, and it's all gone. And it just doesn't sustain itself. And I think there's a couple of reasons. One is it's very hard for people to see the injuries that don't happen. And so everybody knows when an ACL tear occurs. What they don't know is when an ACL tear didn't occur. And so, you know, if you have a high school girls soccer team that 1 year 3 girls tore their ACL, and then next year you did some preventative work and 1 girl tore their ACL, they still had a girl tear their ACL. So why are they wasting their time with this program? It's hard to kind of get over that. That's why I think that the injury prevention message sometimes doesn't work, whereas the performance enhancement message tends to, people understand the value of that. The other important thing I would say is all of this ACL injury prevention stuff, it's not like riding a bike. So it's not like you learn how to do it and then it stays with you. You've got to keep doing it. So there's been some research into how long you have to do ACL prevention work for it to be effective. And it's been shown to be about 6 to 10 weeks. But there was a great study out, I think it was in Denmark, at a professional, and it was handball that they do over there. So it was a professional women's handball league. And I want to say they had 2 divisions of handball. And so there are a whole bunch of teams, you know, maybe 6 or 8 teams in each division. And in one of these divisions, they did an ACL prevention program. And they had a dramatic reduction in ACL tears in that group. And at the end of the year, everybody patted themselves on the back. They said, we did a great thing. You know, if you look at the numbers, we had a statistically significant reduction in ACL injury risk. And the examiners went away and they published their report. And the next year, the two divisions, the rates of ACL injury were identical. And so the important thing is this stuff about being a better athlete in terms of controlling your body, it's got to be ongoing. It's not something you can just do and then you keep. It's got to be something that you take with you. The last piece I would comment about that is it's just a product of the world we live in where time is valued. And, you know, a coach says, I've got 1 hour to spend with my athletes. I can't afford to spend 10 or 15 minutes of that time doing this work. And again, just not to keep harping on it, but that's why I think this performance enhancement is such a big key, because that tends to be more valuable to people than injury prevention. Is that?
Yes.
Specific exercises you could suggest to prevent the twisting damage, to strengthen the knees for twisting or ankles.
So the question is, are there any specific exercises to prevent the twisting of the knees and the ankles?
I mean, we're going to be doing that in the stations. So as soon as we're done with this, we're going to go over these stations and learn about some of those things.
Yes.
Seems we're talking about girls who tend to have more patella tracking problems. Are those girls more prone to ACL injury, or?
Are women who have teletracking issues and injuries more prone to ACL injuries?
So far, there hasn't been one specific factor that's been determined to be the key factor of why women are more prone to ACL injuries. There have been talk of hormonal factors, anatomic factors, muscular factors, neuromuscular, but patellofemoral tracking by itself has not been isolated as a key factor. But patellofemoral tracking can cause a lot of pain. So trying to adjust those in general is usually a good idea. But from an ACL prevention, that has not in itself been isolated as a key factor.
Yes.
I was wondering if the therapist thought there was one sports brace better than the other.
Is one sports brace better than the other, is the question.
You're talking about the one that, yeah, you're talking about the one they get after?
Yes.
I mean, there's all different kinds, depending on your insurance, I believe, is the one that you get. I've seen all different ones. No brace fits anybody perfectly. I mean, they do fit you for it, but everybody's got different curves and whatnot. So, I mean, they fit you for it prior to getting it, so it'll fit you. But I wouldn't say there's one specific one that's better than the others. I mean, they're all different companies make different ones, but they're all they do the same thing. They prevent hyperextension of the knee and the lateral movement. I wouldn't say there's one specific one. You guys don't think there's one better than the other?
I don't recommend wearing a brace after.
Right.
The reality is that there's no research to prove that actually bracing is better than not bracing. Some people do it. My general guideline is I tell people first season back, but I definitely defer more to the physical therapist in terms of what their level of function is, how strong they are, what their activity is. And that's more important to me than any brace. So I really wouldn't get hung up on brace post-op. It's more important to make sure you have a knee that's ready to go back to support than the type of brace.
Yeah, I've had patients that girls that they leave and they don't need one. I don't recommend one. They don't recommend one. And they're good to go. They're strong. They don't need one. But then I have patients that would like them to be in one for just, a little bit, and then they're not in it, and I've never seen them again, so.
And I'm guessing some of that has to do with the homework.
Some of that has to do with homework, yes, absolutely. The two specific patients I'm thinking of were on completely different spectrums of doing their stuff at home that they were supposed to, and then not doing their stuff at home.
Yes.
Are there any types of programs locally for aging athletes that may not be insurance related? For instance, if I did some of these things right now, I would probably flunk a lot of them, to be honest with you. Unfortunately, with insurance costs, with $4,000 deductible each time I would go to therapy, it's $100 away. What can I do?
So the question is are there any programs locally that are designed to help any athlete that are not necessarily insurance-based?
I know Mario Martino used to have a gym program at his practice. Is there any, thought about anybody else doing anything like that?
So, I mean, there are, I think some of the therapy practices do have kind of sports performance programs that they will offer. The one comment I would make about that, so where I did my subspecialty training in sports medicine was out in the Los Angeles area. And out there, the therapy that I worked the closest with, the therapists were Pilates instructors. And one thing that I found beneficial is there's a lot of overlap with things like Pilates and yoga, where what the things that they're working on are the same kind of core strengthening, movement control activities that physical therapy does. Now they're not identical, and I don't want to offend anyone and say they are, but I think there's a lot of overlap there. And so what I often recommend to people who are interested in doing something that sustains beyond their physical therapy is to join a Pilates program. I think they get a lot of the same overlap.
Just along the lines of what John was just saying, I totally agree about Pilates and core. And it's a really, really big deal that what people don't realize how weak their core is. You just point out, I'll go do those things and I'll flunk. And I did the same thing with my children. I made them do single leg squats and they were wobbling all over the place. And they're great soccer players, but I told them how important this stuff is. And to the point where we implemented Pilates instruction in our therapy group because of that. So if you have access to a gym or to an athletic trainer that can spend a little bit of time with you, that's not the same as a physical therapy visit, which, yeah, I understand it can be very expensive, but Pilates and core strengthening are a great way to start, especially for the aging athlete, to prevent this type of injury. Because if you can strengthen that core and you can correct these things like the dynamic balance and stability, those types of things with core strengthening, you can be a non-statistic. You can prevent yourself from tearing that ACL and continue to go down that path.
Oh, yes.
Can you talk a little bit about ACL news, the experiences there, after done everything they were supposed to do, and occurred again and investigation experiences?
So the question is, what can be done about repeat ACL injuries even when someone has been diligent about their homework?
Well, you want it from a therapist perspective or a doctor perspective or both?
Okay, so my perspective is that's kind of like an oxymoron. I don't think maybe they have done all of their homework. If they tear the other side, it's possible that was just they don't have stability of the other leg, the other knee, and that's why they tore it. If they re-tore the side that was fixed, maybe they weren't doing their homework. Maybe they did go back too fast. Maybe they were doing something they weren't supposed to do. These guys have seen and repaired a lot more ACLs than I have. I'm younger than them, by the way. So, they might have a better idea. I mean, I guess there is a chance, yes, you doing everything you're supposed to and re-tearing it. But I'm gonna go out there on a limb and say that maybe if you do re-tear it, you didn't do everything you're supposed to do. But maybe they guys will disagree.
I'm going to disagree a little bit. There's certainly athletes out there that do everything and they re-tear. And then now it's our job to figure out why that happened. And it depends. There's a hierarchy of ACL injuries to the knee. One would be the best, if you've torn your ACL, the best is an isolated tear of the ACL. After that, if you've torn your ACL and a meniscus injury, well, that's a step down in terms of prognosis. And after that, if you've torn your ACL and you've torn your meniscus, and also, by the way, you have an articular cartilage injury, so it depends. So if you're talking about just an isolated ACL injury with no other factors, now we can figure, and they've done their physical therapy and they were strong, now we can figure out why. Was it misplacement of the tunnel? So a surgical error or a surgical placement that wasn't exactly where it should be. That's a possibility. Was it a level of a repeat injury which basically would have torn their ACL in the first place? So that could be. So you really have to find out why this person retore their ACL. Now the other thing is, which I see more revisions, is was there another injury that wasn't detected? Was another one of the ligaments in the knee, specifically the anterior lateral ligament, which is now starting to really become more evident to us in terms of revision surgery, was the anterior lateral ligament, which does give rotational stability to the knee, was that also injured and not detected? So there's an anterior band, just anterior, just in front of the lateral ligament, that contributes to rotational stability of the knee. And if I come across a revision ACL, very often now I'll do an anterior lateral ligament reconstruction as well, because that person has a little bit more rotational instability than was originally detected. And we've actually gone back and looked at why was the anterior lateral ligament kind of now all of a sudden discovered now versus 30, 40 years ago. It's been discovered, it's been in the literature for a very, very long time. And the reason it's kind of fallen off the radar was at the same exact time as the introduction of knee arthroscopy, where everyone said, oh, everything's inside the knee, let's do everything inside the knee. When in actuality, this ligament that's on the outside of the knee was also torn. So if I see someone that has a real, that test that Dr. Kluge showed with the person in the operating room, if I see a high-grade pivot shift, that's called the pivot shift test. If I see a high-grade pivot shift test, or I see somebody that's a revision, like everything was done right, doc, and then she retore her ACL, I'm saying she, because it's commonly she, then that's a person that I'm going to revise and do an anterior lateral ligament on as well. Sorry if that confused you more.
Are there any other questions? So we're very excited about the next part. We have brought in from multiple different area practices, people that will allow you to try some of this functional movement that we're talking about, some of this dynamic stability. You can talk to all of them. We're going to have different activities at each station. We have Dave Armett and Christy Abel. They have, as Dr. Kluge mentioned, developed the 3-act slide, and they have their 3-act slide here. You can put your booties on, and they will show you how you slide and move your body in all different directions. We have Jessica Plumley from the Center of Rehab at BMC, and she is over in the corner. She's going to talk about the vastus medius. She's going to talk about your quads and have you do some exercises there that you can test it out. Elise will be talking about more of the active movements. She's got a ladder over there, so you can really start moving a bit and try that. And Dr. Sprague will have a video of what happens in the actual surgery of repairing an ACL. I have a mirror out there that I will get out, so if you want to try this muchly talked about one-legged squat test. You can test that out and see how your knee moves or stays stable as you're doing a one-legged squat. Finally, I ask that if you would be so kind to fill out the evaluation of our presentation that you'll find on the table and leave it at the table as you're leaving. We would greatly appreciate it. We are trying very hard to make Berkshire Sports and Wellness a program that is helpful to the community and all the athletes in the most broad description ever of the word athletes of Berkshire County. So we hope that we can use your feedback to do that. And so please go and check out all the stations. Thank you.
Here, these blocks are adjustable. We can make them smaller if that or somebody can do different varieties of exercise options. But the ability to sort of have that soft knee and know that I can off the leg, at the same time, you don't want to land the strength of the open knee. Right? So I soften, I load up, kind of load my backside a little bit, and able to drive across. But then as we can start introducing different rotational patterns, to start getting athletes so I go around a clockwise pattern that kind of asks for certain muscular demand, and then I can go counterclockwise as well, which also changes how I use specifically my hip and muscles on my buttock, powerful muscles that are very helpful.
A lot of times people will be on a court, they might not have something like this, they might have something like more along the lines of the board. Either one is perfectly fine. You can either do this position where they're laying on their back with their knees bent, or it can also be done sitting in a chair, squeezing, maintaining that adductor strength, straightening out the knee, holding for a few seconds,
So we can now create
and just not letting the knee wobble. You don't want to let the ball go anywhere without having that contraction. And with that extra contraction for the knees, it gets the extra VMO, the nerve muscle. So I was just telling her, this is what it looks like here. I'm not going to stuff. Often causes a lot of, you talked about the telephone earlier, right? To make it a little challenging, you can kind of go side to side. You can use it for crossover and kind of make sure your this one I call it muscular. You can use it for jumping forward walk, but it's in diagonal. And you can use it just to kind of come together. You can step out, your feet together, and then you can do the backwards. Since
You can do a lot of things. And this is really convenient. You don't have to take it out of fields, step forwards, everywhere you have it. Absolutely simple. Right. So teaching people. And you should always do it down lay flats instead of here.
We were like non-stop.
But you can also use it.
You want to show me that again, Yaz?
Make sure you're really getting your step width long enough. You can, but a lot of it's really for getting those muscles to fire. So you're really using it.
No problem.
To get your feet moving. You can get low. You can get high. You can also use it for jumping.
I can't believe this. This is the exact idea. She's like, I thought the same thing. This is amazing.
And sometimes use these for warm-ups so that they again are working on getting the body moving, actively, quickly, and firing.
Down on our elbows, we're going to try it that way. No. Sure, you can. Is that added? No, but we can add a pad for sure. There's that whole flexibility, piece of trying to get through it over here. Yeah, you're really helps.